Hey, what's up? It's Patrick. It's after work. It's 6 o'clock in the evening, so I'm pulling overtime tonight. And even with two other nurses helping me out with two of what would have been my longest and most complicated visits of the day, still did a lot of running around. I think I saw 5 people, 5 visits, and a couple of them were pretty lengthy for their own reasons. And I didn't realize till I made it to the last visit and I pulled out my notebook to chart that I left my wireless network card at the last person's house. So Monday morning, I'm going to be making a stop there first to pick up my Wi-Fi card. But I think I can just make that work with the schedule. Like, I'll just put him down for a visit on Monday, so that'll be the first place I go. I think that's how I'm going to have to deal with it. Yeah. So, I got a little bit of homework to do tonight. I got to respond to the other classmates' assignments. That never takes very long because the requirement is only 50 to 75 words, and it's counted as part of the assignment that I myself did, And I'm kind of making a game out of writing assignments, like when I'm assigned to write about something, making something that I get a perfect score on, but that no one has anything to say about. That's been a little game of mine lately. And I'm starting to get pretty good at it. It used to be, like when I was starting off in these classes, I would write something with the goal of as many people responding to it as possible. And that was fun for a while. But I was getting perfect scores on all of those. So I had to kind of up the challenge a little bit. So next I started to write assignments that would evade the actual topic. And I still got perfect scores on those. And then now I'm writing assignments that nobody else has anything to say about, and still getting perfect scores on those. So I don't know. I'm gonna switch it up a little bit, keep it interesting. I think in Nursing 530, my last assignment was, oh yeah, I said this already, the nurse's obligation to society and all that stuff. I've got an analytical essay due on Sunday about the 4 central questions of the core curriculum. Let's see if I can remember them. What does it mean to be human? What does it mean to live a life of meaning and purpose? What does it mean to appreciate and understand the natural world? And what does it mean to strive for a more just society, or something like that? Total nonsense, of course. And then for the first analytical essay, I have to relate those 4 questions to, I think, chapter 33 of the Divine Comedy and the first book of Genesis and some book in Exodus or something like that. And the thing that's particularly galling about it is that this, capstone course in the Sacred Heart, core curriculum, this capstone course is just a rehash of things that we did in previous core curriculum classes. So, not only are the assignments themselves meaningless, they're a repeat of previous meaningless assignments. So I'm glad this is the capstone class, let me put it that way. After this, I'll be taking more salient classes. I forget what I have next. Oh, I say that, but now that I think about it, I have an English elective after this. After all of my credits in English, after all the English classes I've tested out of, they're going to make me take more English. I'll have an English degree by the time I'm done with this. No, not quite. I just passed a street called Lover's Lane. That's funny. Yeah, so I was kind of behind the 8 ball all day today. I was an hour late to my last 3 visits of the day, but nobody seemed to mind. They're like, "Oh, no, that's okay. We're not going anywhere. We're just glad you're here." I had to call a couple of them and let them know I was going to be late, and then I was even later than when I told them I was going to be there. Which is not very professional, I know, but it was a very challenging day organization-wise. But I have had some pretty tricky clinical issues today. One involved pain management, persistent increasing pain that was resistant to increasing doses and frequencies of opiates. So, I asked the medical director, or I asked the attending MD for an adjuvant therapy. He's like, oh, how about Motrin? Oh, wait, no, that's not good because of the bleeding. How about some Tylenol? Like, yeah, thanks, okay, we'll give him some Tylenol. I've been giving him Tylenol, he's taking Tylenol. And, but I did get a referral for this person, I got a referral to a pain management MD, so that's good. We'll get a fresh pair of eyes looking at it. And then in another, very long visit, there was a very elaborate but important thing to work out about how, the course of events that led someone to become one of my patients. There was some, ambiguity and some misunderstanding about it, and coordination between multiple different doctors and clinics and stuff, and it took a little book work and, phone calls and searching around and trying to figure out whose plan we should be following, or if there is a plan. And had a very, very challenging bowel and bladder case today that's been very frustrating. I'm not sure how much of it has to do with caregiver compliance, are the caregivers doing the things they say they're doing, or how much of it is just the physiology itself. A trend that I've noticed is that patients of mine who have spent any length of time in specifically dementia patients of mine. Let me go back a second. Specifically dementia patients of mine who have either been in the hospital or they've been in acute geriatric psych or any of those places. Big red flag, big warning sign. You call up for a report and you ask, well, when was the last recorded bowel movement? Oh, I don't know. It doesn't look like they were writing them down. And I was like, wow, really? Oh, wait, my little thing just went on here. Okay, good, I'm still on. And that's just unconscionable. That's just absolutely negligent and reckless. And so the pattern that I'll see is that these people will end up having very distended, poor-toned rectums, and lower intestinal tracts, to the point where they just keep getting constipated over and over again, no matter how many laxatives you give them. So my new trick up my sleeve, which I hadn't considered before, but the medical director of our agency suggested to me when I was talking about the difficulties that I was having with management of the symptom, was glycerin suppositories. Glycerin suppositories. I hadn't even thought of that. Of course, I knew they existed, but the problem is that there's no tone in the rectum, and that's where everything is collecting, and the person can't push it out. So the idea is to just lubricate that passage and keep everything moving that way. So that's another step. I haven't had to go past laxatives fail, give a suppository. If the suppository doesn't work, give a fleet enema, increase the laxatives, and if it happens again, repeat the cycle. But I've had a couple of patients lately where that protocol does not work satisfactorily. And when I ask doctors for recommendations, they're like, oh, well, they're not taking the max dose of this yet, just increase these things. Which for some people works and some people it doesn't. But yeah, it's really an art to symptom management, I'm finding. There's a lot of things to consider, and there's a lot of different ways of approaching it, and there's a lot of ins and outs, so to speak. But yeah, that can those are the things that keeps me thinking about it when there's symptoms that are not that are difficult to control or resistant to interventions. It's like, well, what do we try now? I've got another patient who is thought to have a small bowel obstruction, and this patient hasn't moved their bowels in a month, and the previous agency that they worked with said that they tried everything and it's not in the lower tract and it's on the upper tract, and because this person is dying of some other disease. They're not a surgical candidate, and so the answer is just, if pain increases, give more pain medicine. And this is the second patient that I've seen that was in that boat. There was something about the disease process that caused their intestinal tract to be completely obstructed, and there was no possible intervention except to provide comfort. And I mean, out of all the situations that I see people in, that sounds to me like the worst. I mean, I've taken care of people with dementia and Parkinson's and cancer and heart failure and lung failure and kidney failure and liver failure and all these different things, and an unresolvable intestinal obstruction seems to me to be the worst thing. But I guess everybody has their own idea about what the worst thing is. I know I heard one of my mentors when I was a new nurse tell a family member of a patient of somebody who had dementia that I'd rather have cancer, is what she said. I would rather have cancer than dementia. Neither of them sound very nice, but sounds like there could be a silver lining to dementia. You wouldn't be aware that all this was going on, reduced to the basic sensory inputs like a small child. What is interesting to me, what people are like when they have no memory. It's kind of interesting, like sort of a stripped down or a pure representation of what people are when you take away the story about their lives and who they are and where they've been and where they are right now. You eliminate all of that, and what remains is, tragically, a level of impairment that makes it so people aren't safe to be by themselves, But taking care of people in that situation has been a very profound experience that I wasn't really expecting as a student. It was, something I caught on to right away when I was working in the nursing home, that this was a very interesting challenge. One thing that I thought was interesting about it is that if the unlicensed caregivers, like the unlicensed support personnel, like home health, CNAs or patient techs or things like that, if they're not doing the things that they're supposed to do, you will notice, because the patient can't do anything for themselves. So if they're, for example, not keeping their eyes clean, I will know. I will know just by looking at them. And so that's one interesting thing about it. And then the other interesting thing kind of reminded me of what interested me about the forensic psych field that I did, a short student nurse rotation of about a month or so, maybe a couple of months in. And the thing that was interesting to me about that was that the highest risk, or the thing that was putting their health most at risk of the people who were, living in a medium security forensic psych facility, the thing that endangered their health the most was neglect from their caregivers, which I thought was very interesting. And the instructor that we had, a really amazing woman by the name of Rosemary, she'd been working at that hospital for 20 years and retired out with hazardous duty pension and all that good stuff. She had identified this for me, that this is what she believed, and I believe it because she believes it, that caregiver neglect is the most dangerous thing for these people. So the challenge then, from the perspective of the caregiver, is merely to provide appropriate, competent, adequate, compassionate care to these people, when the other caregivers may have an attitude like, well, these aren't very good people, so I'm really not worried about what happens to them. But you're there getting paid money to care about what happens to them, like that's kind of your job, regardless of what crime they were found not guilty by reason of insanity of, like if anybody deserves to be taken care of, everybody deserves to be taken care of, like if the plan was not to provide them with nursing care, they would not be somewhere where there were nurses, they would be in some other place. They've got nurses in prison, even prisoners get nurses. So So that struck me as interesting, that in the midst of the profession that's supposed to be the most caring, and one of the most professional and the most trusted professions, that a registered nurse would still have this outlook, like, well, they're not a very good person. And this teacher told me, my instructor, this Rosemary woman, told me that she went to a seminar on neurolinguistic programming, which is a concept that I've read a lot about and studied a lot, that isn't really well thought of nowadays as not being adequately supported by science. But her the way that in which she utilized it was that she was training the patients themselves to be more effective at manipulating people. Her rationale being, the reason the patients were being neglected was that they were seeking help and attention the wrong way, and they were burning out their caregivers and causing them to ignore them. So with some guerrilla training in manipulation, she would train the patients to get the things that they need in a better way that doesn't irritate or burn out their caregivers. And from what she told me, this was considered a highly controversial position to take, among her peers, that they're being given tools to better manipulate their caregivers. But the alternative is neglect. That's no good. It doesn't reflect well on anybody. But I think that's an interesting idea. So where both of those link, these are related to dementia care, is that it's an interesting challenge to not just provide care to the people that are ignored the most, but to make sure that everyone else is doing it too. Because you're part of a team. It's not just you, and you can't be doing all the work. So it kind of speaks to the challenges of changing a culture, a large culture or a small culture, of changing behavior patterns that are deeply entrenched, things like that. It's very interesting to me. Well, that's it. I've actually been home for a little while now. I'm gonna go inside, and I'm gonna have to do some charting because I left my thing at that other person's house. So that's what I'm gonna do now. And it's Friday. I'm gonna go have a good time. I'm gonna have some fun. I'm gonna relax, play some video games, and I hope you all have a good weekend. And if not, tough luck.